My name is Jim Smith, and I'll be doing the gastroenterology and hepatology section for the Med Study Board Review. You'll be seeing my creation for the next 4 hours on this videotape. Now, as you go into this, I guess there's two possibilities as you're seeing this videotape. Either you are starting way ahead of time before you take the boards, or it's kind of in that panic zone where you're getting ready to take the boards very shortly. And I have a little different advice for you depending upon which situation you're in. If you are well ahead of time, it's months and months ahead of the boards, then I'm going to repeat to you the same advice you've been told many, many times. And that is, every time you see a patient, read about that patient. Read a textbook, pull up a journal article. Even if it's that 100th CHF patient you've admitted, find something to read about the patient. And then once you read about it, think about how it relates to that patient you've seen today, and how it's similar, how it's dissimilar. And that's the basis of learning based on your patients. Now, I have kind of the same advice if you're in that panic zone and getting ready to take the board soon, in that I want you to approach each board question in a patient-oriented way. Meaning, when they give you that scenario on the board exam, put a face to it. Think of a patient that you've had like that. Or if you haven't seen a patient like that, think of what you'd do if it was a patient. Because if there's one thing you've done right now, and whether you're a third-year medical resident preparing for the boards, or a subspecialty fellow preparing for the boards, or out in practice preparing for a recertification, one thing you've done is you've taken care of a bunch of patients. In fact, sometimes you probably can't even imagine how many patients you've taken care of. You've taken care of so many patients. So that's one thing you have. And in taking care of so many patients, you've developed judgment, insight, internal hunches based on that. And I want you to use those same patient-oriented hunches when you approach the question. Do the same kind of thing you do in real life. If you would really do an upper endoscopy, then that's the answer. Now, but I advise you, and this is the same as in real life too, if the diagnostic test is something that has a little risk to it, like an ERCP, you always have to be cautious about that. And that's what you do in real life, and that's what you do on the boards too. The GI section for the boards is an important section. Year after year, if you look at the ABIM on which section is number one in terms of the number of questions, it's always cardiology. But GI is always number two. So year after year, that's going to be the second most common type of question you're going to have on the board. So it's an important area to learn for the boards. I think it's easy compared to the other sections. It's not that endocrinology stuff that's hard. GI is simple. Sit back, relax. You'll be able to do it fine on the test. And with that, I wish you good luck, and sit back and listen to the tape. This lecture is going to really go through everything that I think is reasonable for the boards. In fact, this is the boards, the whole boards, and nothing but the boards. You're not going to hear about any research that I'm doing about anything that's not either been on the boards or, in my humble opinion, is timed to be on the boards that haven't been on the boards yet. From time to time, I might quote the masters, like Yoda, the Jedi Master. After he took the boards, he says, GI, simple it is. So this is simple stuff. Let me just do a disclaimer about my drill questions. The drill questions, I've got 14 of them scattered throughout this lecture. They're hard to do. I've been doing them year after year. And, I start off with a teaching point, and then I go and find a patient that I've had with that illustrated that point. So almost every drill question is a patient that I've seen or a variation thereof. But when you make it focused like that, sometimes you look at the question 6 months later and say, hey, answer A is just as good as answer B. So I'll point that out at times where I thought it was a good question months later, or where another answer would have been appropriate as well. So without anything else, let's go ahead and get started. There's a few situations where you need to know physiology on the GI boards, and I'll point those out. In fact, what we're going to do over these next 520 slides is there's really only 6 x-rays that are important for the boards. We're going to give you examples of all 6. There's maybe 3 or 4 endoscopic photos that are important, and there's maybe 4 or 5 examples of physiology that are important. That's it. So we'll talk about all those points. I think the physiology of the esophagus is important for a couple reasons, mainly as it centers around reflux, dysphagia, and achalasia. The first part of swallowing, of course, is the voluntary aspect, where you voluntarily initiate the swallow. The upper esophagus, upper esophageal sphincter then closes. The upper esophageal sphincter relaxes. The epiglottis closes. At that point, the smooth muscle in the esophageal body takes over. There's peristalsis. This is involuntary. It takes the food down the esophagus, and at that point, the lower esophageal sphincter relaxes and allows the food bolus to go into the stomach. Now, on the boards, if they give you a patient with dysphagia, and let's throw in some nocturnal regurgitation, where does that workup begin? On the boards, the workup always begins with a barium swallow. All right? Any dysphagia on the boards, you start with a barium swallow. In fact, for all of you who've purchased those yellow highlighters outside, on this slide here, on your textbook, go dysphagia, yellow slide, workup, and then do barium swallow, because that's always the case on the boards. It's not in real life, but that's where you begin. Okay, this patient has an x-ray that looks like this. Big dilated esophagus, tapering down. What's the diagnosis? It's achalasia. And achalasia, year after year, is a favorite on the boards. Almost every year they're going to ask a question about achalasia. The pathogenesis, they're not going to ask about that. Nobody knows. I mean, something leads to ganglion cell degeneration in the myenteric plexus, and nobody knows what causes that. But then what happens then is the smooth muscle in the esophagus loses its peristalsis. There's elevated lower esophageal sphincter pressure, and that lower esophageal sphincter does not relax when you swallow a bolus of food. That's what leads to food hanging up in the lower esophagus and ultimately dilation of the esophageal body. The symptoms are usually long-standing. Most patients will have symptoms that have gone on for years. They have dysphagia for solids and liquids, and that's the key thing. Dysphagia is one of those, it's a great thing from an internist standpoint, because you can almost always get the answer by the history. And they want you to know that for the boards. And when it's dysphagia for solids and liquids, think of achalasia, especially if it's long-standing. Now, in real life, most of them complain more of regurgitation, and almost every single patient with achalasia I've ever seen has been misdiagnosed as having reflux first. That regurgitation is thought to be reflux. They don't respond to PPI, and years later, they come in your hands and you make the diagnosis. But on the boards, they will accentuate the dysphagia part. They might have a cough, especially at night. Occasionally, they'll have chest pain. We're going to talk more about the barium swallow and esophageal motility in just a second. The esophageal motility, I have this up here just to make a point. You do not need to interpret esophageal motility on the boards in any way. These are leads located in different parts of the esophagus, and what you see is when this patient swallows here, there's no movement in any part of the esophagus. The esophagus is silent. Any movement would be all at the same time, but you can see there's just no activity as the bolus would be propelled down the esophagus. So that's the lack of peristalsis. If you're going to make a diagnosis of achalasia, you need all three of these components. You can suspect it without all three, but you really need all three. You need the upper GI, you need the motility, and you need the EGD. Now, on the upper GI, that's the pinpoint that has that's one of the key factors. They have a dilated esophagus. In general, how dilated correlates with how long the patient has had achalasia. You don't see any organized peristalsis. There's going to be a bird beak narrowing at the distal esophagus. The barium is going to be stuck there for a while. As the patient's standing up, the radiologist will say the barium takes 15 minutes before it falls into the stomach. They might see retained food in the esophagus. Don't worry about this point number 7. That's real life, where a lot of them are normal. That's on the boards. There will always be an abnormal x-ray to go along with achalasia. Now, the EGD, that may show a dilated esophagus, retained food. You should be able to, if you're experienced, appreciate that there's a slight degree of resistance at the lower esophageal sphincter. Probably the main reason you have to do an EGD, though, is to make sure there's no tumor at the GE junction.